Hi everyone, my name is AJ. I'm a student physical therapist from Carroll University and I'm currently pursuing my doctorate in physical therapy. Enough about me though, we're going to talk about AFOs and their implications for patients that have sustained a stroke. So that being said, just want to give you a little quick overview. We're going to show you a hemiplegic gait pattern so you get a look at that. We're going to talk about what an AFO might look like in clinical practice. Please remember this is not a comprehensive list by any means. That would be impossible. There are so many different manufacturers out there. Main takeaway with this presentation is that you need to maintain that positive relationship with that manufacturer, with that patient at that center, making sure that you are establishing a very collaborative relationship with both of those parties. So that being said, then we'll move into those pros and cons as the title alludes to, and then we'll talk about that clinical decision to use or not use an AFO with a patient that has sustained a stroke. So that being said, I'll turn it over to that hemiplegic gait pattern so you get a look at what that is. All right. Alright, so you got a chance to look at that hemiplegic gait pattern. I hope you're able to catch that the right side was the affected side. Being the good physical therapist you are, though, I'm sure you did. So now that being said, we're just going to take a look at those AFOs and how they might look in clinical practice. I hope that look at the hemiplegic gait pattern gave you an idea of what kind of structural stability you may want to provide at the ankle. Specifically looking at that right ankle joint and how limiting the plantar flexion during those different phases of gait may be assistive in some ways. So maybe limiting the dragging that may occur, maybe as a safe assisted device. So things may be crossing your mind, and I hope you're contemplating those as we go throughout this lecture, and you got to look at that in that video. So now, like I said, we're just going to take a look at those AFOs. Alright, so you got a chance to look at all the different types of AFOs, but please remember this is not by any means a comprehensive list. There are so many out there, it really would be impossible. And I just want to explain that last slide that you just saw. So that was one manufacturer's way to differentiate the different types of AFOs. So I hope that makes sense. There will be a lot of different types of characteristics that are labeled out there by different manufacturers. Of course, because everyone has their own way, the different materials, different ways to organize, how to measure, and things like that. So now we're just going to move into that pros list. I'm going to give you a pretty long time here to look at all those different pros. There's quite a few slides. So then we'll talk about those just briefly after, just touch on a few of them, and then we'll move into those cons and that clinical decision making at the end. All right. Alright, so I just want to touch on a few of those pros that you just saw. So obviously it's improving gait speed, it's improving gait cadence, it's improving the functional transition towards independence in gait. It's also improving the weight bearing on that affected side. So those are all really great things, right? It all makes sense. Really want to push the use of AFOs. That's what all these pros are saying. We want to improve function. We want to improve quality of life, obviously, through that improvement in function. So essentially, all these pros are really giving you a really good handle of why we really want to prescribe AFOs. But please also remember that there are a lot of different studies out there. They use different types of AFOs. I tried to differentiate as best I could which types were used in the different studies that I did cite, but it really comes back to you and being able to extrapolate that information from the authors as they present it. So being able to apply a different population to the patient case that you see, that's really ultimately your clinical decision. So I hope that you're able to do that and use that evidence-based practice in your future practice or in your current practice. So that being said, we're going to move into those cons. Again, I'm going to show you a list. I got 2 slides here, so I hope you get a good chance to see those. If you have to flip back to those pros just because they were kind of a shorter time that were left on there, I hope you got to read them all. But if not, of course, you can flip back, kind of rewind the video a little bit and take a look at those. I hope you're enjoying the classical music. It's going to continue to play as you get a chance to look at these cons. And yeah, so I'll give you a chance to do that. All right. So now I just want to talk about a couple conclusions that can be drawn regarding those cons that were listed. So one of the things was that the Berg balance scale seems to not be validated as a measure to determine the balance of an individual that has sustained a stroke and is then using an ankle foot orthotic. So in the pros list, it is mentioned that other measures have been validated, such as gait speed, thinking about dynamic gait index, functional gait assessment, things like that. So using different scales would be most appropriate in that case, considering that the Berg balance scale really didn't show a whole lot of change. So be thinking about that in your practice, whether or not to use that kind of a scale. And then I just want to touch on that last slide a little bit more. So what that was a list of things that I came across in my thinking and my thought processes while I was doing my literature search, but I did not find to be addressed by the literature. So things like patient comfort, things like durability of AFOs, things like structural atrophy that does occur or does not occur, depending on what literature may say. But those were things that were not addressed or I did not find in the literature, but things that need to be considered when deciding to prescribe an AFO or not prescribe an AFO to a patient that has sustained a stroke. So another thing to consider is price. If a patient comes to me and says, AJ, I have to pay $55 now for this AFO that you got me, I didn't know that. So I may have overlooked something in that case. I overlooked the fact that I thought that $55 would be acceptable to pay for an improvement in function. So I simply overlooked that consideration, and I needed to do that in order to ensure that I have a very collaborative interaction between myself, the patient, the insurance provider, and then the manufacturer. So I hope that makes sense. So I think that basically wraps things up though, as long as we're on the same page as far as that's concerned. The cons list, again, that last one is more of a subjective thing, things that I didn't really find in the literature, and I hope that you're able to contemplate in your future practice. And now we're just going to move into other notable findings, and then we'll move into the clinical decision making that goes into whether to prescribe or not prescribe an AFO. All right. Okay, so I just realized that at the end of quite a few of my clips, I did say the word all right. I hope that's all right with you. It must be a nervous habit that I have. But anyway, so I want to talk about that clinical decision-making process. It ultimately comes down to three things: your clinical experience, the evidence-based practice approach, and then the patient values. So I just want to touch on a few of those, and then I'll give my own personal clinical opinion regarding the use of an AFO with this population. So first of all, experience. I won't influence that a whole lot, unfortunately, through this presentation. It ultimately comes down to your interactions with your patients in the actual clinical setting. So if you have a bias one way or the other, whether or not AFOs are useful. So then the second component of this is the evidence-based practice component. So I hope that you got a good idea of the pros and cons regarding AFO use. I hope that you come away with a better understanding than maybe you did entering the presentation. So ultimately, using evidence-based practice in your practice, current practice or future practice, we've learned to be a skill, right? So we want to use this skill in order to ensure that we provide the most possible or the best possible interventions to ensure that we get the best possible outcomes. Sorry about that. So I hope that makes sense. And then finally, the patient values component. I value this component to be the greatest. I prioritize it as being the highest as far as my decision making is concerned, basically because I am a novice therapist at this point. I don't have a whole lot of clinical experience as of yet, but even if I did, I still think that I would value this very highly, considering that it ultimately is the patient's decision whether or not to use or comply with the interventions that I prescribe. I want to make sure that everyone's on board and it's a collaborative effort in general. So ultimately it comes back to those cons lists, right? A lot of those things were addressed there. The patient comfort. Do they feel like this AFO limits their ability to feel the floor under their feet? That's something subjective that I've kind of stumbled across quite a few times now that I've worked with patients. A lot of them will complain of that, not being able to feel the floor beneath their feet, or unable to push off, really, because it really limits that plantar flexion. So is that a good thing, a bad thing? Is that limiting their function? So be cognizant of that. And then I just want to touch on my clinical opinion. I do feel that AFOs can be very beneficial, but again, taking on that stance of it depends, which we've become accustomed to that through our experience in school, and we learn to accept that. There is so much gray area in clinical practice, especially in physical therapy. The patient cases vary so significantly from one to another. It's something to really take pride in that you're able to distinguish when to best apply a certain intervention or a strategy given the patient cases. So that being said, I really do feel like AFOs are useful. I wouldn't be afraid to use them in my clinical practice. I do feel like it does vary from patient case to case, but definitely I do feel like they do have a role in providing some functional component to improvement in the patient's status. So I hope that makes sense, but definitely be sure to take on your own stance through your clinical practice. I hope that you enjoyed the presentation. I enjoyed making it. I hope you enjoyed the classical music that was playing throughout. I thought it really classed up this presentation, if I do say so myself. So thank you very much for watching, and take it easy. Have a great day.